Hello again, everybody. The topic here is going to be hemophilia, and although I'm including these in my internal medicine talks, this is a disorder that most commonly presents in children. However, nowadays, because we've got such great treatment, these patients routinely live into adulthood. So you can consider this sort of both. But it usually, especially in test questions, pretty much always, is going to present in a child. Very young child. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. Definitely subscribe to my channel and you'll get notifications every time I put a new video up. All right, so we are going to talk about hemophilia A and hemophilia B here. Now, I've got a number of factor disorders that I want to go into. All of these things cause you to bleed, and they have to do with factors. And that is different from a previous talk that I gave where I talked about issues with the platelets. So things like von Willebrand's or Bernard-Soulier. Those have to do with platelets. These have to do with factors. So they're different and they manifest differently. This is how they manifest differently. So you should be familiar with platelet type bleeding versus factor type bleeding. So they both bleed, but they manifest a little bit differently. So with the platelet disorders, it's mostly superficial bleeding. So you got thrombocytopenia, you got von Willebrand's. It's primarily going to be bloody nose, bloody gums, menorrhagia. They may have an occult GI bleed. They can get bleeding into their skin, which causes petechiae. But for the most part, this is mild. Okay, it's mild. On the other hand, factor disorders, this is deep bleeding. So bleeding into the muscles, bleeding into the joints, hematomas, hemarthrosis. Yes, they can have some mucocutaneous bleeds, but the big thing that separates this is just the depth of the bleeding. They will not tend to have petechiae. They can get bruises. They will be larger and deeper bruises, but the big thing that sets this apart is the hemarthrosis and the hematomas. And these hematomas can get so big that they can actually cause compartment syndrome. Okay, so hemophilia A and hemophilia B. Yes, there is a hemophilia C. It's a lot less common, much less commonly tested. You can go look it up if you want, but I'm just going to talk about these two here. Now, both of these are X-linked recessive, so they will tend to be in young boys. They are caused by a deficiency of factor VIII, which is hemophilia A, or a deficiency in factor IX, which is hemophilia B. They are clinically indistinguishable, so you have to do labs in order to know whether it's A or B. The symptoms are going to be exactly what we talked about with the deep bleeding. Can cause joint pain if you get a hemarthrosis, warmth, stiffness, headache, stiff neck, irritability would suggest a CNS bleed. They can get hematemesis, lots of blood loss through the GI tract, epistaxis, but really look for those deep bleeding symptoms. That will be given to you on your exam. Now, weakness and orthostasis can happen due to chronic blood loss over a period of time, can cause an iron deficiency anemia, and that's common to see. So musculoskeletal bleeding is the hallmark of hemophilia. So you have to bear that in mind because that's how you're going to distinguish that this is a factor issue rather than a platelet issue, although getting a CBC is always useful. Classic presentation is on the exam is a significantly prolonged bleeding after a circumcision. About half of patients present that way. Or a hemarthrosis, for instance, in a young boy. But this is, because it's X-linked recessive, it's almost always going to be in a boy. To diagnosis, if you suspect hemophilia, the best initial test is a mixing study. Now, on CCS, that's probably not going to be part of your initial orders, but this is the best thing to do once you really start thinking that this is hemophilia. However, the most accurate test is factor levels, because that tells you exactly how much factor you've got. So it's pretty definitive. So your basic labs, I would start with the CBC just to check and see if they're iron deficient, and you can get a look at their platelets too. But you want to know if this patient is iron deficient because we'll need to replace that. PT and PTT, that's going to point you towards hemophilia. That's going to be part of your workup for platelet type bleeding as well. What you'll see here is a prolonged PTT. Now, you can also see that in von Willebrand's, but they're not going to have the hemarthrosis. So a prolonged PTT is something we would expect both in A and B. Mixing study, remember that's the best initial test. The PTT will correct in a congenital hemophilia. And I say congenital, we'll get to acquired in a little bit. So basically what we're doing here is we're mixing, we're taking the patient's blood and then we're mixing it with factors. So that if we're replacing the factor that's missing, everything should normalize. And this stands in contrast to something else. It'll make sense in a couple slides. And then the factor 8 and factor 9 level, that's the most accurate. You may or may not include that in your initial orders, but obviously those are the most important tests to get to confirm the diagnosis. In the ED, if these patients present aggressive hemostasis, administer factor 8 or 9, but only if you know they've got an established history of hemophilia A or B, respectively. In the hospital, treat complications, ensure they're stable. Outpatient management for hemophilia A is prophylactic factor 8 replacement and or DDAVP, particularly if it's mild. For hemophilia B, it's factor 9 replacement. So we're just replacing the missing factor. It's pretty simple. We also want them to avoid high-impact contact sports, so no football, no hockey, and when I say football, I mean American football. Soccer might be okay. I would avoid contact sports, though, in general. Anything with a high risk of trauma. This is a hemarthrosis. Pretty obvious. You got this pretty massive swelling, but if you feel it, it might be a little warm, but you're not going to see the erythema that you would see in, for instance, a septic arthritis. All right, so again here. All right, now there is a genetic predisposition here. And as you can see, the only people who are affected are the males because it's X-linked. And this is in the British royal family, and I think also other royal families. I don't know, they inbred a lot. So you can see in the present British royal family, there is no hemophilia. They look funny, but they're not as inbred as they look. Okay, now acquired hemophilia A is caused by antibodies against factor 8. And there's a number of ways you can develop these antibodies, but what they all have in common is that they have these antibodies against factor 8, it deactivates them, and as a consequence, they basically have the picture of hemophilia. So I put here the number of causes. Most of the time it's idiopathic, but there may be an underlying malignancy or a history of an autoimmune disorder. Suspect this in a woman or a girl with hemophilia-like symptoms just because they tend to be X-linked recessive when it's congenital. So if you've got a female patient with hemophilia-like symptoms, consider that it's acquired. Or someone who develops hemophilia-like symptoms later in life, i.e. not in childhood, or somebody who has extensive cutaneous purpura. In the absence of low platelets or von Willebrand disease. So acquired hemophilia A is a lot less likely to cause hemarthrosis, and it's more likely to cause this really bad cutaneous purpura. To diagnose this, you do a mixing study. Okay, now why is this important when I talked about mixing studies earlier? Remember here, you have antibodies against factor 8. So if you add factor to the patient's blood, those antibodies are going to attack that factor too. So you're not going to do anything, right? The problem with congenital hemophilia is that you lack the factor. So adding factor will fix the problem. But because you have all this antibody in your blood, if you add factor, that antibody is going to attack the factor that you added. So it's not going to help. So the PTT does not correct. The treatment here, there's a number of ways you can go about this. You will not be expected to know this on your exam, but a common way is by giving porcine from a pig, factor 8, because that antibody is less likely to attack that. There's also this activated prothrombin complex concentrate. You may hear that thrown around. Now, there's also treatment-related inhibitors. This is kind of along the same lines, but basically the way that this develops is that you've got a patient with congenital hemophilia, you're giving them factor 8 or factor 9, and then they develop these antibodies. And so basically they're developing an acquired on top of a congenital hemophilia. And so this happens fairly frequently. And so it is a feared complication because once they develop antibodies, giving factor is not going to be as useful. So you're unlikely to be tested on this, but if you are, look for a patient who had a pre-existing diagnosis of hemophilia and now they've been getting factor concentrate for a period of time and now they're starting to develop symptoms again. What do? Get a mixing study. The mixing study will now not correct because they have these inhibitors. So to recap, hemophilia is a deficiency of factor. A is factor 8, B is factor 9. They look identical. They're both X-linked recessive, so look for a young boy with affected maternal uncles, just like any X-linked recessive disorder. It commonly presents after a circumcision, so look for that on your test questions. Factor type bleeding is deeper, commonly involves hemarthroses and hematomas, whereas platelet type bleeding is more superficial, think menorrhagia, gum bleeding, and so forth. The best initial test is a mixing study. It will correct in congenital hemophilia. The most accurate test is factor levels. If there is no correction, and usually this happens after the diagnosis, after you've been treating them for some time, think of treatment-related inhibitors. If they're older and they develop hemophilia-like symptoms, think acquired hemophilia. Treatment, replace the appropriate factors, especially for the congenital hemophilias, and the development of hemophilia symptoms later in life is likely acquired hemophilia A.